Welcome to project number 3 of the Genius PT project. We are talking with Joletta Belton again for the 3rd time, which is fantastic. Joletta, thank you again for joining us to entertain some questions. We have Naja here with us today, and Juan is going to be joining us shortly. And so we're just really excited to be talking a little bit more about the patient perspective and really diving into understanding the patient's perspective in persistent pain, because ultimately that's why we do what we do, right? And so in this project, we've been thrilled to have Andrea and Jane first share their story around what it looked like to be treated from a biopsychosocial perspective instead of a biomedical perspective in regards to their rehab. And then Joletta's done a couple of sessions with us, really sharing her own story, which was fantastic, but also sharing her perspective on collaborating with your healthcare professional to rewrite your narrative, to rewrite your story. And so thank you, Joletta, for all that you've shared with us so far. I'm going to just jump in with a question, and then I'm hoping Naja and anybody else who has a question will just jump in as well. And so my question really is around self-efficacy. So my question is around the importance in persistent pain of creating self-efficacy for patients in order to help them rewrite their narrative. So in other words, I think often what happens when we see a patient in persistent pain is we do an assessment, we tell them what's wrong, we tell them what bits and pieces are broken, and then we give them exercises or strategies to hopefully do. But more often than not, we are caught up in clinic in doing techniques to patients to help them or to try and help fix their broken bits. But I guess if in persistent pain, there's less of an issue around broken bits and often more of an issue around the sensitive nervous system, I wonder what your thoughts are on how to build self-efficacy with patients earlier on and how to really help them to become the agents of change.
I think that's a great question. You've touched upon, can you hear me okay?
Yeah, perfect.
Okay. I just wanted to make sure. Touched upon so many things that lead to that loss of self-efficacy that persistent pain patients may have too, people living with persistent pain. Because like you said, a lot of times we go into care and we are told what our broken bits are. And even in persistent pain, we're still often told that it's broken bits and that the sensitive nervous system or changes that might be taking place more whole personally are not addressed often in our care. And it still becomes about finding where the damage is, or it becomes about very biomechanical explanations. So we're told those things that are broken about us and then told what we had to do to fix it. So our locus of control is taken away from us in all of those encounters. And then that's repeated over and over and over again. And so people who might be very self-efficacious, is that the right word?
Yeah.
In life in general, you know, in being able to still work or deal with their family, like run their family at home and all these other areas that they might be incredibly self-efficacious, when it comes to their pain, they might not be. And as with everything that comes to being human and being a human in pain, it's complex. And all of those encounters that might be stealing that locus of control and stealing that self-efficacy lead to certain expectations then too when you go into healthcare. And it can be, you can be in a place where you just want that fix. You just want that person to be the person who fixes you. And there's no even recognition of the role that you can play in being the agent of your own rescue, as Bessel van der Kolk calls it. So I think it's so important that first step, like we've talked about in the last 2 sessions too, is to really hear that person's story. And a lot of times people think that would take too long, that it would be a waste of clinical time, because then you're not really figuring out what the problem is. But so often the problem is found in that person's story, or the what is going to motivate them is found in their story. Learning who they are as a person is going to guide that path forward in care, and it will enable the clinician to then find ways to help that person be more self-efficacious, to have more self-efficacy when it comes to their pain and the things that they need to do for your pain. I always laugh in looking back at my experiences, because I joke about clamshells more than anything else, because I feel like that was the exercise that was prescribed to me the most often. And I will never do another clamshell in my life.
And you'll be good for it. It'll all be good.
Yeah, and I'll be fine. I am fine. Maybe
Right,
enough,
right.
I haven't done a clamshell in like 5 or 6 years. But when people are just given those types of exercises, how does that relate to their life? Often that connection is never made for them. They have no idea how these exercises that they're going home with apply to their lived life, their real world experiences. And it's only through conversation that you figure out what those gaps are, that you figure out that those connections aren't being made, and then potentially find different ways of finding things that they can do that are active, that will get them moving, that they actually enjoy and are meaningful to them and give them value. And it can be, so to get to do these things, we need to take some steps to get there. And this is what that looks like. Let's work this out together. And it's that co-creation of that path forward that is so important, rather than just being told what to do, which then you have no locus of control. It's not yours at all. And it doesn't even apply to you. Or it can feel like it doesn't apply to you, especially in so many clinics, just given the mimeograph sheet of exercises that everybody is given. That's not for me as an individual with this unique problem, which might not be unique, but it's unique for me. Like this is different for me. You might see it all day long, but for me, this is the first time I'm experiencing this, or, have been experiencing this for a while. That if it doesn't feel like it applies to us, it's not going to apply to us. And it's not going to have any of those things that you want to encourage some inherent motivation for people to do things when they go forward. But if that path is created together, if meaningful activities or valued activities are discovered, and then you work together to figure out how that person can get back to those things, like what a greater way to both get them moving again, get them back to the things that they enjoy doing, and give them some locus of control back too, which is going to help with that self-efficacy and give them more confidence. For me, I lost so much confidence in my hip, like so much confidence in my leg. I just didn't trust it anymore. For the longest time, it's really hard to have that self-efficacy and do all of these things when you don't even trust the body part that you have. But you don't know that someone might be experiencing that if you don't have a conversation about it, if you don't have those discussions that lead to that. And that's why I think that hearing the patient's story, eliciting more from them, especially for people who might have a difficult time sharing anything beyond just what they're expected to tell, like the symptoms, the quality of their pain, the VAS scale, or whatever it might be. It might take some time and skill to elicit more from the person living with pain to figure out what those steps could be or what those barriers are to moving forward.
I'd like to say,
Naja, do you have a question? Go ahead.
Yes, I have a question. Because wonder if you don't follow the traditional model and you just ask about a diet or just your shoes and such, and they're not seeing how these things, they meaning the patients, are not seeing how these play a role in good quality movement patterns, pain-free movement patterns. Like, how can you get them to shift to seeing that? Because that's kind of like, that's one struggle I go through down here in the, it's a pretty retired community where traditionalism is, well, can I get my exercises and do them at home and then come back to the next treatment session? So how can we shift their perspective a little bit after hearing their story, listening to their story, and you're hearing that their pain is listed with XYZ? Is it every single time, or is it just sometime of the day? Is it all the time, or is it just in the afternoon? What footwear are you wearing? So that's a question I have. Because I try to read the individual to see if they'll be open to it, and if they're not, I fall back into traditionalism. But then I'm afraid to give them exercises because they may be doing them wrong, even though you have them out in the picture, and they'll come back and say they flared, and that's the last thing I want. But you lead your own therapy. You're taking charge of your own health.
Yeah. I think there's so much that we can talk about there, and I appreciate the question and sharing some insights into the struggles that you have with the people who come to see you in your unique population. And one of the things that I would say is to expand the view of what the story can be, so that it's not just about pain and what their symptoms are, that it's more about their life. A lot of times when people, especially people with persistent pain, are coming in, all they're expected to be to talk about is their pain and their symptoms, rather than the broader perspective of their life. And there might be more gold in that broader perspective of their life, and more entry points into coming to kind of a shared understanding of what that best path forward might be. One of the things that like Howard Brody, who is a former family physician and a bioethicist, talks about, and John Lawner, who wrote a wonderful book about narrative approaches in health and social care. They talk about how there's two narratives that come to every encounter. The clinical narrative, which is based in your knowledge and expertise and education and training and all of the things that you know might be best for this person living with pain. And then that person with pain is coming in with their own narrative, their own explanations for their pain, their own ideas of what might be best. And it's about kind of negotiating between those two narratives, rather than just trying to replace their narrative with the clinical narrative, because it's probably never going to happen. Ideal is never going to happen, because ideal isn't real life. So then it's making some compromises and seeing ways that those two narratives can come together to a shared narrative that's created together. So maybe diet and footwear and those things aren't the thing that is focused on, and you start with exercises and that sort of thing that they expect, and then through discussion and dialogue, continuing to kind of plant some seeds that there might be some other things that can help facilitate if certain things are uncomfortable during their day. Like one of the things that I find really valuable is talking about meaningful activities for people, because people who want to engage in a certain activity and are limited by pain, that can be an entry point into figuring out ways that they can engage with that meaningful activity without being so impacted by their pain. So it can just open up a different window for exploring these things. And in those conversations don't have to have anything to do with pain to figure out what those things are, if that makes sense.
It does.
We become so pain focused in our conversations that we forget that the person lives an entire life with that pain. And so understanding that life can help, and nothing is ever going to be perfect. And that's something that is really hard for everybody to come to terms with, whether you're the clinician or the patient. There's never going to be a perfect scenario, or maybe there is in some cases, but I don't know of them. Making those compromises and negotiations can be a starting place.
Joletta, you brought up a really good point, because then I realized when you were talking, when am I having these more pain conversations or when I'm not? In the women's health, I'm not. I'm looking more at their quality of life. How would it feel? It's the general population that it's different, because they're being referred by orthos who are right next to us, because it's a big clinic,
right,
with 300 doctors who will send them on over and say they're going to give you exercises, so they already have this expectation. Mm-hmm. So I have thank you for saying meeting them, halfway, or at least meeting them where they're at, so to speak. And exercise, just give it to them and then see how it fares with them.
And have a conversation about it. Use that as a jumping off point for a conversation, and explore a little bit what they think of those exercises, how they think they might be beneficial to them, what they feel like those exercises help them do, can open up those doors. And then you can have those conversations potentially down the line with them, like you're having in your other setting that you enjoy more. Bringing some of that into the ortho clinic, bit by bit, and just seeing how, playing with it. We've talked before about experimenting with some of this stuff, trying these different ways, having conversations in these different ways as an experiment, just to see how it goes. And it doesn't have to be perfect. None of it has to be perfect. And those exercise sheets that you give can just be a starting point for a conversation, rather than the end point of the session.
You know, it's
Okay.
interesting as I listen to both of you discuss that piece, Naja, I wonder as well. So I wonder, I use a lot of distress questionnaires in my practice. So I standardly measure central sensitivity, looking at the CSI score. I standardly measure catastrophization, looking at the pain catastrophizing scale. I
Okay.
standardly measure fear avoidance, looking at the TSK. I standardly measure low positive affect using the PANIS, for example, depression, anxiety, stress, using the DAS-21. So I have these series of questionnaires that everybody gets, whether they're an orthopedic patient or a pelvic health patient. And for me, that's really part of the big jump off point where I can start to say, hey, you know, you filled out these distress questionnaires and, you know, you're scoring 59 on the central sensitization inventory. And what
Ah,
that really says is that you have a sensitive nervous system. Is it okay if we talk a little bit more about that? And we've probably already had a discussion about pain and what pain is, and that pain is a sensory and emotional experience. And so, you know, screening for distress and screening for things other than physical biomechanical problems is going to allow you to have that conversation.
oh, that's brilliant. Because sometimes, I mean, the basic traditional tests, I'm like, I know this is it. I know, I find myself saying, and sometimes even saying out loud, like, I'll go through the motions, but it's, that's not one of the root causes. I know to say just one root cause, but that's not one of the root causes. But screening for distress.
Right. And so, you know, it's interesting. I've been practicing for 33 years and I'm now at the point, and it took me sitting on my hands, and it took me really willfully reframing. I no longer look at posture. I no longer, because there's no such thing as ideal posture. What the heck does it tell me when I say, oh, their right shoulder's a little higher than their left and they're blah, 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 right? It doesn't change my clinical practice at all because I know there's no such thing as ideal posture. Variability is good, you know, and if someone really has an acute mechanical problem, I'm going to educate them for a short period of time to avoid certain postures. But I no longer have this thought process. You know, I used to be the queen of lumbar rolls, right? I worked for the Canadian Back Institute for about the 6 or 8 years of kind of the earlier part of my career. And I swear I sold more lumbar rolls than anyone else did. I don't sell lumbar rolls anymore because there's no such thing as this is ideal posture. But, you know, so I've seen that transition, but unfortunately, I don't think it's happened broadly enough in
Yeah.
physio, right? And that's where we get hung up.
And sometimes, like, especially because I had lumbar rolls,
Yeah,
and I used one in between my scapula, like, as well, so that I
right.
could have my shoulders back.
Perfect posture. Yeah.
Perfect posture, and it was disastrous for me. And it also supported my biases as a fitness professional. So I was a firefighter before all this happened. I was a peer fitness trainer for us. So I had all the stupid weekend certifications and FMS and TRX sports medicine and kettlebells and all of these things where posture is very emphasized. I had also gone through a GOSU like towards the end of my time in healthcare, which is a posture therapy. Like they do all the postural plumb lines and everything like that. I used to measure like my ASIS and
Right.
all of these things and try to fix them. And I mean, they even talk about it being a crooked human. And as I was starting to get better, and I would still do those, like the pictures that we could upload, I was still totally crooked, but I was getting better.
Right.
Like, so those two things might not be related. You know, my uneven shoulders and my rotated hips and all of these things might not actually be what is causing my pain. And so much for me that was important, was getting permission to move in all sorts of ways and not having such a rigid and controlled movement, which, I mean, your movement variability just shrinks and shrinks and shrinks when you believe that there's only one right way to move, especially when it comes to just everyday life. It shouldn't be that much work. Like, you shouldn't have to be constantly focusing on how to sit and how to stand and how to lay properly. It was so much exhausting work for me after a while. But getting that permission from a clinician, from your physical therapist, to move in all sorts of ways and do the things that you want to and like to do can be such a weight lifted, you know, like, I can do these things, because you don't know, you forget that you can do those things, that you're capable of doing those things.
But in order for us as therapists to actually give our patients permission to do that, we have to lose our own biomechanical biases, right?
Yeah.
And we have to
Or
kind
else you'll be terrified.
right, because it's like, well, that's not safe. Well, we're not fragile. I keep just saying, we're not fragile as a human species. We are actually very robust, right?
Yes.
And when we are sore, we feel broken, but we're not broken. We're just sore, right? Now, if you fracture your femur, you are broken. But there's a great surgical technique for that. Thank heavens, right? And after that,
feel
they
amazing
do.
well.
Right. And so do nerves and so do muscles. And this whole dysfunction sort of comment that we have in physio, I wish we could get rid of that term. Because what does dysfunction mean, really? Right?
I agree with that. I used to say that, and I almost found myself putting that in someone's note the other day. I said, no, there's a better word for this. There's a better word for this, because that's not it. Let's just call it what it is. She has trouble doing blah, 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 blah.
Right.
And yes, it was more for me to type, but it was clearly laid out. It was probably during eval. Yeah, it was clearly laid out, and it gave me something for when I do see her again. To see exactly how she's doing, and we can work from there, or to see what her quality of life is at this point. Blah, blah, blah. Yes.
It's interesting. I will go back to what Sandy Hilton says all the time. In persistent pain, there's only three things that are wrong. Something's tight, something's weak, or the nervous system is sensitive. Right? And if we keep it that simple, none of that is broken. Right? It's just alterations in tissue function that all can be changed. We can desensitize sensitive tissue, we can strengthen weak tissue, and we can increase flexibility in tight tissues. Right?
And I just like to pair on, a couple of things. Greg Lehman is always great on. I'm not going to use his words, but
all right, thank you.
Greg, calm stuff down and build stuff up.
Yeah.
And but Ben Cormack also makes that brilliant statement about, we're not a car. We're not a machine. We aren't broken. We are a biological organism that can respond to stress and adapt. The question becomes, when do we calm stuff down and when do we build stuff up?
Right.
And so then that's where Sandy's stuff fits in. Do we need to desensitize? Do we need to strengthen? Do we need to move? And being able, and Naja, I just want to say, I love how you just did that self-check. Like, there's got to be a better way to do this. In fact, it's so simple, it's ridiculous. They're having trouble with this. And I think that's just kind of a great way to pull that in together. Juan, are you with us? You'll probably need to unmute yourself and come on in.
Yes.
Welcome.
I just rolled like the driveway I just came through.
I love it. In the car, ready to go. That's awesome. Welcome.
Right. But thank you so much for having me. Like, I'm like a super fan.
We love having you. Do you have any questions for Joletta? I don't know if you've been able to kind of watch any of our talk on the patient perspective, or maybe you just have a question from a therapist perspective on something that patients need to we need to understand more about kind of their perspective.
Not questions specifically, but just in working, just, as I work more with a lot of patients, in looking at the whole picture with people, especially with pain, pelvic pain and other things that they may have going on. It's just what I love about a lot of that you guys talk about just in general is just kind of pick apart and see what truly is going on. Because yes, they may be coming to you for like, oh, well, I've got this problem, or I can't do this, or I've got this pain, or I have pain when I urinate, I have pain with sex, or whatever have you. But it's like, well, what else is going on? And I was talking to I was telling someone else about a story because of her stuff going on, and I had a client who, because of her pain, she started to develop these notions and these perceptions of she had a lot of sexual dysfunction, a lot of pelvic pain. She was married, and her thing was, she was like, I don't know what to do. I feel like he's going to divorce me, and it's like, whoa.
in it, you know? And it's like, okay, well, let's take a few steps back and kind of see what's going on, why you feel that way, and let's break everything apart bit by bit, and then see where we need to start and what we need to do.
Right.
And so a lot of what she developed was not even necessarily correct information, but it's just based on what she was all going through. That was the narrative that she kind of created for herself. So
Right. Right. Joletta, that sounds like she did a really great job of kind of listening to her narrative, but then helping her hopefully to co-create a new narrative around that. Right.
And eliciting more, like
Yeah.
being able to hear that that initial problem that the person is coming in for, and then recognizing what context is this happening within and what else is going on. Like, that's so insightful and lends to so much, such a richer understanding of what that person is going through, because how terrifying to think that your husband is going to leave you because of all of this, and how much additional stress and load is that creating on this person's nervous system and systems in general. And being able to just let them give voice to that, which they might not have said aloud to anybody before, allows them to start working through some of those things too. And that can be really terrifying for, physical therapists to hear. Like, I don't want to hear about everyone's life problems, but it's no different than what bartenders do and what, hairdressers do. It's just being human and allowing someone the space and the place and the safety to share something that might be difficult and might be contributing to their experience, because we're only made of so much stuff. So if you're under all of this stress and you're worried about all of this other stuff that might be going on, and for a lot of people with pain, it could be relationship things that they're worried about, it could be financial things that they're worried about, their ability to still work, and those are big, heavy things. Those are the biggest things in our lives: our relationships with our loved ones, our ability to work and earn an income, it to be financially secure, food secure, all of these different things. So if all of that becomes a part of the worry and stress surrounding that pain, it's of course going to affect that pain. You don't have to fix all of those things. And I think that's a really important thing to recognize too. You can hold space and listen to those things without having to fix it. You don't have to fix these big issues, which are much bigger than any of us. But just allowing people the safety, space, and trust to be able to share those things can be a really powerful thing. And then that starts that conversation where they can start coming to a new narrative. Like, maybe this isn't going to happen. Like, being able to like Juan said, bit by bit, start tackling some of those things and letting them connect their own dots. Like, okay, maybe like this is not true. Maybe there's another explanation for this, or maybe there's another way forward, or another way that this is all going to turn out. Maybe there are some different possibilities to explore here.
I think as therapists, we're often so afraid that we're overstepping our bounds and becoming psychologists when we ask some of these sort of connection type of questions. But I love how you said, Joletta, you're really just giving them the space to share their story. And often, if you ask enough open-ended questions and ask them to kind of problem solve and work through what they're talking with you about, they will often recognize what the next step is.
Yeah,
right?
yeah.
And so you can help facilitate that, but it's not your job to fix that, right?
Yeah,
And
yeah.
so I think that should make us a bit more comfortable in this space, hopefully. But it does take skill.
It does. And I love Maxine Misiak's paper, like when she talks about creating the safe container and all the things that it creates, but in forming a therapeutic relationship to create that safe container where those exchanges can take place.
Right.
And I just think that's such a valuable thing, and not an easy thing by any means, especially because no one is taught how to do that. And none of you were taught how to do that in school. There was no discussion about safe containers and making space for people's stories. So it's hard. It's a new skill to learn and to practice. And I think that is something I really want to stress, that it takes practice, and it's never going to be perfected, and it doesn't ever have to be perfect.
You can put a smile on your face even though you don't want to be in that environment.
And recognizing your own stuff is part of that too. Recognizing what you're bringing to that encounter too is such an insightful and can be a really helpful thing too. Just being able to recognize, like, I'm going in here a little more wound up than I am upstairs, and I just need to take that into consideration during this interaction. I think that's a really, like, just being aware of our own stuff that we bring to encounter is important too. We don't have to share all that stuff,
No,
but being aware of it, with at least not in that environment. But sharing some stuff about your own humanity is important too, or sharing the stories of other people that you work with, or just sharing human stories can be really valuable in the clinical setting too. It's okay to be a human as a clinician. It's okay to be human as a physical therapist. You're not taught that either.
No, we're not. And so we're not taught a lot of this. And I think that's a great way to kind of wrap up this discussion and to challenge not just the five of us on this talk, but all of those who are listening to us, to really start to challenge our own beliefs and values as physical therapists as to how we sort of upskill ourselves in this very, very important area. If we really are going to move towards a biopsychosocial perspective, we need skills in motivational interviewing. We need skills in cognitive behavioral therapy. We need skills. And so, but as therapists, we don't value those skills, and hence we don't invest in them. And hence it's hard for us to change our clinical practice.
Right. And also skills, you know, the stuff that Joletta was speaking about are basic coaching skills.
yes, they are.
And they
Coaching,
can be practiced, and they can be learned, and they can be so powerful. And the idea of the safe container, for those of you who are kind of like listening going, I'm not sure what's happening here when they're talking about that, you can go back to our earlier Genius Project. I think it was Project 1, right, Carolyn, where we spoke with Allison Sims about the Therapeutic Alliance. And we did talk about empathy versus sympathy, and that space, and just really creating that space for somebody to be. And I think most physical therapists came at this profession because they wanted to help people. So tap back into that original thought that you had for entering this profession, and then it may not seem like quite such a leap of faith to get there, because it's just a different way that may be more effective in helping people kind of cross the thresholding and start finding their way back to the life, you know, the life that they want to live.
Mm-hmm. And I think that looking outside the box too, like I love the references to coaching, which is probably more in reference to like health coaching, but even athletic coaching has so many skills that can be brought to these encounters too. And there's sports psychology exists for a reason, and that's because athletes are complex humans too, and they deal with all of these psychosocial factors as well. And so the athletic coaching world has done a lot of great work, especially when it comes to things like self-efficacy. There's a huge field of study in sports psychology on self-efficacy, that tapping into those types of resources can be really, really helpful too, especially for those who are working with athletes or more athletic-minded people in pain too. Or if they're athletically minded themselves, it might break down some of those barriers of this is not my forte, or this is not my field. It might break down some of those barriers and make it a little easier to access and take on.
Excellent. Well, thank you again, Joletta, for answering some questions for us. Thank you, Naja and Juan, both for joining us and for asking some great questions. And Susan, we hope your throat and voice and bronchitis piece gets better real soon so that you can share your wisdom with the world.
Thank you.
We'll see you in Project 4 next month. Take care, everybody.